The Pediatric Lounge, a podcast taking you behind the door of the physician's lounge to get a deeper insight into just what docs are talking about today. From the clinically profound to the wonderfully routine and everything in between. Pediatric Executive Development System, or PEDS, is a dynamic, transformative program designed to accelerate the growth and development of the leaders in the field of pediatric entrepreneurship. PEDS takes a hands-on approach to problem solving, addressing real-time situations within your organization. More than a theoretical course, it is a practical platform that accelerates learning. Look at our link on the show notes for more information. Hey, George, it's great to see you again on a Tuesday afternoon.
Hello, Dr. Bravissimo, as I call you. Today we have another wonderful guest, Dr. Lisa Costello. And the topic that we're going to be discussing today is an interesting one, advocacy from the big hospitals. Let's take it away.
Dr. Lisa Costello is a dedicated pediatric hospitalist and assistant professor of the West Virginia University School of Medicine Departments of Pediatrics. Born and raised in Weirton, West Virginia, she embodies the mountaineer spirit of hard work, determination, and service to others. It's a pleasure to have you, Dr. Costello. Thank you for joining us.
Thank you for having me.
We always start out by asking our guests, why did you become a pediatrician?
My story of becoming a pediatrician goes back to actually a visit with my pediatrician. I remember coming home from a well child check and running to the Encyclopedia Britannica when they were still on shelves and looking up what it was to be a pediatrician. I just remember feeling a sense of support and safety and true care from my pediatrician. And that made me consider doing something like that in my life. And as I went through, as most people typically do, considered a couple other different career paths. I knew I liked science and helping people. And then in high school, I actually switched pediatricians because my pediatrician had retired. And it was the same kind of feeling that I had in inspiration to help others, to care for children and be part of children and families' lives, to help them be whoever they want to be and help them get support and help them grow and develop and have a chance to follow their dreams. So that was my story of wanting to become a pediatrician, being inspired by my own and having a love for science.
What a wonderful story. You look way too young to be reading the Encyclopedia Britannica. That's something George and I did at a parent's house. You live in West Virginia. In West Virginia, I don't live far from West Virginia. I'm about an hour's drive from the state line. But West Virginia is a more rural state than the northern part of Virginia. How is practicing pediatrics, especially pediatrics, different in a more rural state than it is perhaps in a bigger city like Long Island and Washington, D.C.?
I've only practiced in West Virginia, so I'll yield to the viewers who are listening for your experience in a more urban setting. So I've only practiced in a rural environment. I'm from the northern part of West Virginia, so just about 30 minutes west of Pittsburgh. Go Steelers. And I ended all my training in Morgantown, West Virginia, which is where I live now with my husband and my daughter, and work for the university, as you mentioned. And so really, even being from the northern part of, we were somewhat different than southern West Virginia. And in work I've been able to do in my state and through public health, I've had a growing appreciation for even the more rural areas. I'm a practicing pediatric hospitalist, so I care for children from all over the state of West Virginia. And it can be really challenging to get services in some of the areas. It is common for us to have individuals who don't have electric or don't have running water. And we have to consider those things when we're determining if we need to discharge a patient or if it's safe for a patient to be discharged. Additionally, we have limited specialists. And so where I practice at the hospital in Morgantown, we have the only cardiothoracic surgeon for pediatrics in the state and have for some time. So we are fortunate to have many different specialties. We have some specialists that we engage in telehealth. And so in a rural state like mine, getting that subspecialty care can be really challenging. For instance, we don't do bone marrow transplants on children in my state. So if we have a patient who needs to have a bone marrow transplant, they're going to have to go out of state to get that done. Certainly that adds stress to the family and travel and stress to the child. And certainly we want to ensure that the child gets the care that they need. So we've been working to expand outreach, and telehealth has helped to help us reach into the more rural parts of our state. With that comes the challenge of our state does not have great broadband. And so many places in our state, they don't have broadband, not because they can't afford it or not because they don't want it. It's literally because they don't have access to it. There's been a lot of work to try to expand broadband. I think that's the electricity of our time, and to ensure that all individuals have access to broadband internet and the resources and opportunities that provides. And in regards to clinical care, the opportunity that can afford for telehealth. Certainly, we have to be creative in how we use our resources and try to pool them. And also being mindful, it can be very common for a person to have to travel 3 or 4 hours one way to come seek care for their child or their loved one. So we have our challenges. We also have a great sense of community. And I haven't practiced anywhere else, but we see that time and time again. We've seen that in the pandemic, and we see that in other outreach that community groups do in order to help one another. And as a people, West Virginians are strong and resilient and wanting and willing to help their neighbors. I'm grateful to be a West Virginian, and it's truly an honor to get to provide care in a place where we have limited resources.
The broadband's a problem in rural America because they call it the last mile. The internet providers will get it to the main highway, but then to get to the smaller roads or the farms, it could be 2 miles of putting down wire, and they just can't do it because there's no return on investment.
Now, is this hospital that you work at, is that a community hospital or a children's hospital, academic center?
I work at an academic center, so I work at West Virginia University. I'm credentialed at 5 other hospitals that are either within our health system or not. I do work at some of the community hospitals in our state. Where I'm mainly housed is at the Academic Medical Center. We just opened a free leaning children hour a year ago in September of 2022. So that was exciting, and that has allowed some growth in resources to have that in our state. So we have seen, as many other states have across the country, some of our community hospitals are providing less and less pediatric care. So that sends more and more children to, I guess is the title of the show, it calls the big hospital that we have in Morgantown.
Bone marrow transplant and cardiothoracic surgery, those are not like bread and butter pediatrics.
Absolutely, certainly. And it also depends upon what the child needs. We frequently will have children sent from other academic institutions, even in our state, to have access to a specialist. Again, we're grateful to have them. It's just sometimes we only have one, if we have one at all, which certainly that can be challenging on that provider as well. But there's that sense of community and that sense of providing the care to an underserved area that I think really inspires and motivates individuals to continue their service.
I have a question about the way healthcare is paid for. Like these it's unusual. It's not done every day, but you do sometimes have a kid that needs a bone marrow transplant. If they go out of state, will Medicaid pay for the service?
Oh, good question.
In my experience, if it's a service that's not covered within the state, then there are arrangements that are made with other hospitals. Certainly, there's a lot of hoops that have to go through to get authorization prior to it happening. And so in my experience, if there's not a individual who can provide that care in your state, the insurance still needs to provide a way to cover that. And then it becomes a matter of of where that will be geographically, where you're located could impact. I already mentioned it's common for people to drive 3 to 4 hours. You have them go out of state. That increases the travel time as well as accommodations. And there's many different considerations that need to get taken into account.
And then you mentioned, and this is something that I'm very concerned about, is the prenatal pediatric deserts that are being created throughout our communities and the maternal infant hospital beds that are being just snuffed out by big health systems. How big of a problem is that in West Virginia?
We certainly have seen, as I mentioned, pediatric units close or just facilities start to invest more in other service lines. Certainly, as I mentioned, sometimes there might only be one provider for a whole rural community. That is the case for primary care as well. And if that individual retires or has an illness themselves or has something in their life that precludes them from being able to provide care for others, that can very easily create a service desert. And I think telehealth has helped some. However, at the end of the day, there are some conditions or some counseling that needs to happen in person, whether it's a physical exam or additional test or something of that matter that can't be done through telehealth. We've seen some places get more mobile units. I think when it comes to maternal infant care, certainly making sure that there's access. And we have seen some birthing units get reinvigorated as there's been more support, as at least in my state, we've seen more health systems start to take over or work through operative agreements for some of the smaller hospitals. And that in itself provides more resources, sharing of providers and sharing of resources that can then help some units reopen. However, certainly I think as we feel the crunch on specialists, if one community has one OB and that individual has to take time off for whatever reason, there's a gap in that coverage in a desert. It certainly is a challenge, and the more rural you get, the more challenging it gets.
What else? In the Long Island area, you have these big systems just basically taking over everything. Now, I don't know if the number of residents increase and specialists are increasing, but they're making these big hospitals. And then the smaller hospitals that try to refer, I'll give you an example. I tried to refer from our little smaller pediatric hospital, a 6-week-old that had some kind of a liver lesion and failure to thrive. And nobody could explain what in the world that liver lesion was. They did not want to accept. They said it's not a justifiable. The child didn't gain weight in a week and a half and has a liver tumor suspected, failure to thrive and vomiting. If that doesn't warrant the transfer, I don't know what does. They said, no, just send them home as an outpatient. We'll reach out to them and do the workup clinic as an outpatient, not English speaking family. They would have to drive an hour to get to where they got to go in the big monstrosity of the center. And that was terrible. So we sent her to another organization where I had a relationship with the people there. What did they do? They took her. The next day later, child got intubated, of course, still intubated, ended up having some kind of, I've never seen it, a 6-7-week-old baby having a merciless diverticulum with a congenital band wrapped around the gallbladder. And that's what was the cause of her. Did you ever see that?
Oh, wow. That's it. Just in case my heart aches. I would have accepted that patient or that to me. But I certainly can hear that. And I have to certainly be mindful of, is my specialist here? If I only have one of that here, that I can accept that patient. But certainly in our state, we've seen that as well, where we've seen bigger systems take, like I said, start to be in charge of others. And we, in our state, many a times in the hospital, we do get outreach from community pediatricians. Seizure activity is probably one of the biggest ones that I see, where the individual comes and it's going to take them months to get into the neurologist. And so they come instead to our ER or get admitted so that they can get that workup.
We have the same problem in Northern Virginia. We don't have enough neurologists, and they don't even keep a waiting list anymore. If you have a seizure, you send them to the children's ER.
Yeah.
and then they get admitted, and then they see the rounding neurologist for that week because they just don't have any. It's no longer like a year waiting list; it's 2-year waiting list. Like this
Yeah.
is you can't run it like that. What we're seeing in reverse is the big systems, and with some shame, they call themselves not for profit, and they're taking over the community hospitals, and they're closing down all pediatric lines of service because they can't make money off of them. And so now you have to drive 30 miles from Manassas, Virginia to Fairfax, Virginia to get into the children's hospital. 30 miles is not a lot compared to what you're describing, 2 or 3 hours.
Yeah.
But it's not fair for the children's hospitals to dump everything on them. They're overworked, underfunded. They can't hire and recruit enough subspecialists. And then the bread and butter pediatrics, real broncholytic, a kid that's dehydrated, and asthmatic that just needs observation and oxygen for a day or two, can be taken care of in a lesser acuity hospital and leave those bed open for the more complicated cases that are going to come up for at the children's hospital. And not to mention the amount of misdiagnoses, small and big. And I'd like to relate these 2 cases recently. One was a little infant who was seen in the urgent care and was not feeding well, but wasn't particularly tachypnic. And the father brought him back for his 2-month-old child the next day just by a stroke of luck. And the kid was retracting. And as soon as the dad said, he hasn't been eating very well, but the doctor in the urgent care said that was okay. And for me, that's like a fire alarm. Infants don't eat well, don't wake up to eat. There's something catastrophic coming. And I sent him to the children's hospital, and he was in the hospital for 7 days with rhinovirus pneumonia. No, nothing you could see in the x-ray. He was just hypoxic for 8 days. It's not that I'm a great clinician. It's just that I learned if you're under 2 months and you're not feeding, you're not waking up to feed, that is not a baby use at home. And then the other one to me was also very sad. They had a telemedicine urgent care visit, and they were diagnosed with hand, foot, mouth disease. The mother wasn't convinced, so she went to the community hospital where there's no longer pediatricians in the ER, and the adult community ER doctor told her she had true hand, foot, and mouth disease. The only problem is that this young kid didn't have lesions in the hands, the buttocks, or the feet. All the lesions were localized to his face, and he had severe eczema. And it started as a fever blister. So he really did not have hand, foot, and mouth disease. What he had was eczema hepaticum. And he could have lost an eye, maybe not, but he had lesions all over his face. And he needed a cyclovir. And that is not a very difficult diagnosis, but the kid could have lost an eye. Yeah. And we see stories like this over and over again. It's distressing that in my career, I saw where we stopped treating children like little adults, how we improved care at the community level, and now we are losing all of that in the time span of 20 years.
Well, yeah, that's because in the ERs, they don't think you need pediatricians anymore because the adult medicine can take care of it. I have a case, the reverse of what you had there. Goes to the ER with fever, cold, cough, congestion, severe drainage from the nose with some fever blisters around the nose. So they said he has cold sores. So he gave him cyclovir. Went home, another week of sick, cold, cough, runny nose, poor eating, not getting good, gets admitted. Goes back to another ER. Fortunately, they saw a pediatrician at that time who recognized that this kid is really sick. It was terrible impetigo. Ended up with secondary bacterial pneumonia. Ended up in IV antibiotics for a couple of days. Once you put them on the antibiotics, the rash went away. The lungs got better. It's give you a pulse ox of 92%.
And the sad part is like Prince William County has 100,000 kids in their K through 12 system. So there is a population to be served. I can understand when you live in a rural community where the whole county has 15,000 persons, how you're limited to as to what you can sustain in that little county and people have to travel. But you got 100,000 kids. And that's not counting the kids under 5. and you just wash your hands and say, go up the road, get care over there, let them take care of you. So to me, it's very distressing. So, Dr. Costello, why did you decide to become a leader in advocacy, and what drives that passion?
I think the stories that you all been sharing, I have stories like that as well. I think for me, advocacy allows me to step away or beyond from caring for that individual person, which I think people, when they talk about advocacy, being a pediatrician, or I think even being a physician, advocacy goes hand in hand. It's what we do. And individual advocacy is incredibly important, advocating for that individual patient. Like we said, if a child does need a bone marrow transplant, ensuring that they can get the care they need where it's able to be delivered. Advocacy also allows you to step beyond that and go to the community or the state or the federal level. So I have had the opportunity to serve on my state's Children's Health Insurance Program board when we had a board, and any decision I made on that board would impact the tens of thousands of kids that we had enrolled in the Children's Health Insurance Program. So I've been out of practice. I graduated medical school over a decade ago. And so if you count even the people I've cared for during my residency, it'll take me many more decades if I'll ever reach caring for tens of thousands of individuals. But advocacy allows me to move beyond that and to help enact policies or encourage policies to be implemented that impact tens of thousands, or in my state, even millions of people, as well as trying to protect bad policy from being enacted. Because sometimes we have to go on the defensive to say that's not a good idea and this is why, and share the stories. So the stories that you each shared, I have stories like that. The stories are really what I think help us be effective advocates, because we're able to share real life examples of how a certain policy impacts the people we care for and the individuals who are elected officials or policymakers, and really at all levels of government, whether it's the executive branch, legislative branch, or the judicial branch. There's opportunities for advocacy in each of those that allows us to move beyond. And for me, it's a big part of wellness. I feel that I can speak up on behalf of others and my profession, and that's incredibly rewarding. And to have the opportunity to do that and to form relationships and build coalitions to help speak out on behalf of children don't have a vote. And we were talking a lot about children's decisions being made for them. So children don't have a vote. And I feel as adults, that's obviously an important part, but we can also speak up for them and try to improve health outcomes, improve access to care, improve public health, and the list goes on and on. So that for me were some of the reasons why I feel engaging in advocacy is so important and really baked into what we do in pediatrics. And I would also say what we do as physicians.
Yes. And how do you think is the best way to impress on policymakers and politicians the importance of spending or investing a sufficient amount in maternal infant health for better outcomes?
Sharing those stories are really our currency of seeing those situations in which there is room for improvement. And I think sometimes it's hard to amplify what happens. And a lot of times with policymakers, it has to be a person who they know or someone that is in their community and really makes a lot of noise. However, as physicians, we see this time and time again, and we can really take those stories and elevate them in a HIPAA compliant way, or if you do have permission from the family to share those stories, as well as to share the data that we have that shows the importance of it, and in educating individuals that children really are the future and that we have to invest in them to be able to improve their health and help them lead helpful lives. At the end of the day, they're also the future workforce. They're also our future defense. So we really need to invest in child health and maternal health to make sure that we have a bright future as well.
And to me, it's because you come from a more rural state. A farmer will always hold back its best crop for seeds for the next season. And that's how they reinvest on their land. And that's how they keep making money and feeding the country. And if we don't invest in our best, which are moms and children, we will not have a crop to the future of this country. I don't understand why people, it's a simple concept to me. We need to invest in children and moms.
Unfortunately, the pediatric spend in the insurance carriers' eyes is budget dust. 2%. They're not important. For the people that run the hospitals, children are a medical record number with a dollar sign, only $1 sign. They're not the big procedures. They're not the cabbage. It's not the shunts that they put in. It's just an office visit, a hospital visit. Not important.
It's the future.
It's not important. Today, they work for today and tomorrow. They're business people.
And that's where I think that we have to speak up and to be that voice for children. And we need to engage other members of the community, including parents, to be able to share those stories and show that value. One of my favorite advocacy sayings, I didn't come up with this, I've heard many people say it, but with advocacy, if you're not at the table, you're on the menu. And I think sometimes children aren't represented at the table, or physicians or pediatricians aren't represented at the table. And that's
They're not.
Why it takes individuals to advocate, to show the importance of that, and know that it's a marathon and not a sprint, and that policy change can take time. However, I've had the opportunity to be a part of different opportunities that have led to change. And also just at the county level, I think the pandemic brought that into account. Maybe you don't want to have to go to your state house or the DC. There's a lot of decisions that get made at the community and local level, and engaging in your school board or your local school, as you were talking about the number of children in that one county school system. Being engaged there is important, and really you can have an impact on the decisions that are made there.
Yeah, unfortunately, a lot of systems are run by business suits, not enough white coats with business experience. And they will come to you, doctor, and say, you know what, doctor, why don't you sit down, do what you do best, tend to the patients, we'll take care of the money. They will tell you that. They will tell you, sit down.
Yeah, and that's why I've been involved and I just completed my term as president of the West Virginia State Medical Association. And we launched a physician leadership program to help physicians have the tools to be leaders. At the end of the day, you are also an individual. If you're a citizen of the country, or if you're not, if you're a voting individual, the business suits can't tell you. They can encourage you who to vote for, but at the end of the day, you go into that ballot box and you pick who you want. You can form those relationships. And I think that's where you have to really work to engage and learn those leadership skills. And again, try to find a way to have a seat at the table and to help move medicine forward. And that's for me why I'm involved in organized medicine as well. I think it's really hard to engage physicians sometimes. I felt that. And so we want to say other people are doing this or that. And some of that is going to have to be responsibility on us to speak up on behalf of patients and our professions, because I served for a brief time on our admissions committee for medical school. Everybody at some point wrote why they wanted to go into this field of work. And I think returning to that, and I frequently reflect on that when I talk about the advocacy work I do, that I don't get compensated for. It's what I'm doing because I feel it's the right thing to do, and that it can and have an impact. And that at the end of the day is why I went into medicine, because as I shared at the beginning, I had a pediatrician who made me feel safe and supported. And that was something that I wanted to have an opportunity to do for others. And what I try to do is to do that through advocacy and health policy, to try to make things better for even larger groups of individuals.
Yeah, unfortunately, I get a lot of students that come to my office, and I have yet to meet the one student that says, Doc, I want to be like you. I want to be a pediatrician. It doesn't exist. It's very sad.
That's a whole other problem.
I know.
So to your problem, Dr. Costello.
Director, so I'm fortunate that we have a few. So I think that there are, I think the whole graduate medical education is something we have to continue to go down the pipeline and show that pediatricians are some of the happiest and rewarding, and that we need to, again, it goes back to sharing those stories. I see it all the time that a lot of times we don't share our stories, and we need to be better at that as physicians, as the healthcare community.
That's why this podcast was born, to share stories and elevate great physicians. Right, Herb?
That's right. So to your point, Dr. Costello, I think one of the things that ails our specialty is that we have lost hope and we have lost our voices. And everybody says the AAP is going to solve that. The Medical Society of Virginia is going to solve that.
No chance.
Well, the Medical Society of West Virginia is going to do that.
No.
That's the way the politics works. Politics is all local. So you need to get out of your office with 2 or 3 of your mothers who are struggling to do whatever it is that's important to you. Go over to your local elected official, whether it's, I don't know, the mayor of the town, or whether it's the state legislature or the state senator that represents your district. Sit in their office, arm in arm with the moms, and say, this is affecting the people that you represent. And we need to talk about this. We may not agree, we may not have the money for it, but we need to talk about it. And then, as you said, it's a marathon. You come back and you visit them again next year with another 2 moms that are having the same problem until it gets in their psychic. This is a problem for the people I represent. And I'm going to have to find some sort of a solution for them, because it all at the end of the day becomes local. And if you don't play your part, there's nothing any one of these big institutions can do for you, because they don't have the money, the resources, or the time to go get involved in every local political engagement. And we just need to own that. We need to all get out there and tell our story.
And I would even take it a step forward. We need to elect individuals who are pro-child health and even consider running more. In my state, we have less than a handful of physicians or health-trained individuals who are elected officials. And so we now have 2 pediatricians in the United States Congress. There needs to be more, and we need to do what we can to support individuals to run for office, as well as to ensure that they're electing individuals who are pro-health and being informed voters. And so I think it's even going, what all the things you said are important, forming those relationships, which is what we learn to do and what we do as physicians. But I think that at the end of the day, it's going to take members, and thinking that somebody else is going to do it for us, that's not worked out too well. And so I think we need to take some ownership in that, and again, have that baked into the profession of what we do, that it's part of our job, and that's what we should be engaged in addition to being a part of our job as a community member.
Absolutely. You're the immediate past president of the American Academy of Pediatrics for West Virginia chapter and the society. So when you were the AAP West Virginia leader, what stands out as your biggest win in your work with that?
So I was the president during the pandemic. We played a big role in a lot of the pandemic associated outreach, as well as the vaccine rollout. And in our state, I think one of the things that we really work hard on for advocacy is maintaining our strong immunization policy. West Virginia has the recommended AAP policy, in that we only permit medical exemption as a requirement for school entry. So we do not allow non-medical exemptions. This is something we have to defend each session and each year to ensure that we maintain that policy. And as a result, we have some of the highest school-aged immunization rates in the country. And so maintaining that policy continues to be something that I feel was a victory, particularly in the setting of the pandemic and all the different changes that needed to be made. We did a lot of things, and we're a small, mighty AAP chapter, but I think providing those stories and that advocacy to maintain that policy was certainly an accomplishment that we're very proud of, and that we hope that we can continue to be proud of for years to come as we maintain that policy and do our part to maintain that policy in West Virginia.
What would you have to see across the finish line that still needs to be finished?
We are, as everywhere else, and the National American Academy of Pediatrics has declared the mental health crisis that exists. And in a rural state like mine, we're seeing more and more. Every time I'm on pediatric wards, I have at least a couple of children or teens who have tried to take their life. And we are working to enhance and and expand mental health resources, and also make sure that primary care providers have the tools they need, because they're the first line in seeing a lot of this. And as we talked about before, the length of time it can take to get in to see a specialist. So I think we're seeing more infrastructure around mental health. However, we still have a ways to go. My state has a really significant foster care and kinship care challenge, substance use disorder, and all that goes back to mental health and having resources. We're continuing to work on that. And certainly, I hope that we can start seeing more and more programs and resources that are developed that can help the communities and the kids, because it certainly is a crisis, and it's bad. I don't know a way to sugarcoat it. I guess that's the reason this podcast exists, is a look into the pediatric lounge. It's bad. I'm seeing kids well under 10 want to end their life. I'm not even sure when I was that age, I knew what that would mean. And I think that the toxic stress that children see and experience day after day, it's really heartbreaking. And I think that making sure that we have caring adults and caring individuals for kids are going to be important, and as well as the support they need for whatever they're facing.
Yeah, that issue is very sad and very difficult because the resources are not there. Doesn't matter what community you live in.
Yep. It's bad. We know it's bad. It's been bad for a while, yet nothing happens.
It's overwhelming to know that the number 2 cause of death between, I think, the 10 and 14-year-olds is death by suicide.
Yep.
We've eliminated so many horrible diseases of childhood, and now you're watching your children die in despair and without need. It's very sad. What are you most proud, or what do you think was your biggest achievement when you're the president of the West Virginia Medical Association?
I briefly mentioned it. We launched a program called Physician Leads West Virginia that brings leaders and aspiring leaders from around the state. It's led by one of my colleagues, the president before me, and I had the opportunity to see it get over the finish line, and we're about to recruit our second class. And I think I work in an academic institution. Our medical students, they get exposed to so much, as well as residents. There's not as much leadership training and education that needs to happen. And so providing an opportunity where we could bring together physicians, and we do a lot of what we've been talking about. What do they see in their community? They feel motivated. A lot of it comes from frustration. I'm sick of seeing this happen. How do I change it? And there's a lot that can happen, obviously, at the policy level when we talk about advocacy, but there's also a lot that can happen through philanthropy or private groups or leaders working together to build resources or programs that really do have an impact. So that was a great accomplishment, and I'm proud to say that we were able to launch that and that it has been well received, and we're looking forward to continuing that program for years to come.
That sounds like a phenomenal program. And then what is there left to do? I know there's a lot, but what did you think that you could accomplish that just didn't get across the goal line?
It goes a little bit about what George was saying. To get people involved, I think I hear that a lot. Oh, I'm not going to get involved with this because nothing ever changes. And I think it showing and encouraging individuals, there's strength in numbers. The more individuals that you have that are part of organized medicine is important. We need to have engaged members that are able to network and share the story of their patients and their communities and our profession. And so I think that's an ongoing struggle as we've seen over time, less and less engagement. And I think we really need more of that. And we have dedicated, committed members that do really incredible work. The more individuals that we can have joining forces really can make a bigger impact. And I've seen that. And I've seen how strong coalitions can elevate an issue, having more individuals reach out. I've heard it from policymakers. I've heard it from businesses. They take notice when people come together and work towards a common goal. And so I hope that we started improving engagement a little bit, like through programs like I talked about, our leadership program. However, there's more work to do and to show physicians that somebody else isn't just going to do the work. that you have to be part of the team as well to help move things forward. If not, decisions are going to be made for us, and they're not always the best decisions or in our best interest or in our patient's best interest.
Yes. And I think the other thing is you don't need to ask permission of anyone. You are a member of this community, whatever your community is. Go talk to the policymakers in your community about what's concerning you. Don't wait. Go do it. The worst they're going to say is no, and you're no better off or worse off than you were before you went out there. But don't be afraid. Go out there and say, this is bothering me.
And I think being a resource for them, I run a rotation. I did it as a med student myself, where we have students rotate through our state capital. And the number one thing every student says, they are always surprised at how little the policymakers know about medicine or about issues that they're voting on. Depending upon where you're from, legislators look different. In my state, it's a community elected or public elected force. So you have teachers, accountant, coal miners, some physicians, some people who work in different fields, engineers. They don't have medicine background. So you really can be a resource for them and explain to them why whatever policy that they're voting on or trying to enact, how that really does impact individuals or kids. And so that's always the one thing that students say. They're like, I didn't appreciate how much they really don't know. And then when I educated them, they then were like, oh, this has been helpful. And I think being a resource for them is really important, because that's what you're the expert in. You're the expert in child health, and you have those stories, and that's what you did your training in.
Yeah, and we have to be a little kind to our politicians, even though lately it's been very small areas of enlightenment in politics, but they have a big job. Even if you're just a legislature elected to represent a county, a district in West Virginia, there's so many issues that there's no way that a normal human being could understand them. And to your point, they need help digesting that and getting it to where they can understand the implications in a simple snippet, because that's all they can digest. It's not because they don't care. It's not because they're mean. It's not because they're this or they're that. They just have a limited amount of hours in a day like the rest of us. And any help they get from someone that means well, that doesn't disrespect them, that doesn't call them names, is appreciated, even if they don't agree with your ideas.
Absolutely. I talk to everyone. I always say in the work that I do, whether it's through the AAP or state medical, we are nonpartisan, but very pro child or pro physician or pro patients. And you can talk to anyone to try to advance that. Certainly, there are situations which there are people that see things more how health policy or science like minded. And so certainly try to get more of those individuals in the seats. However, it's important to talk to everyone and provide that education.
Yeah, because we're all going to disagree on something.
Yeah. We need people like Herb to become president of the.
No way.
Maybe.
Me with my potty mouth? I cannot.
You're a great leader.
I cannot get elected local dog catcher. What else do you want to share with our national audience that I haven't asked you?
Thanks for the opportunity to chat and dive into the pediatric lounge, and thanks for amplifying voices of pediatricians. I think it's just important to be engaged and to find what you're passionate about, and to find a way that maybe you could move beyond from caring from that individual level, which is important. That individual advocacy happens all the time, and we need that. But find what you're passionate about and maybe take that next step. And it doesn't take as much time as you might think. Write an op-ed, write a letter to the editor, make a phone call, send an email, just become engaged in your communities and in advocacy. And it really can make a big difference in the lives of the people you serve. And at least for me, it's an incredibly rewarding experience to get to speak up on behalf of others. I have an 18-month-old, so now I have extra skin in the game because I'm also trying to make it better for my daughter. But I just appreciate everyone. I know it's been a tough time, and we're about to head into another respiratory season. I know that a lot of the work that we do is hard work, and we don't always say thank you, but I'm grateful to have so many people across the country who are working in their communities, many a times not getting the credit, but they're making their communities better. And that's what's really, I think, going to continue to help improve lives for the future.
Thank you so much. Thank you for all
Thank
your
you very much.
I know it's not easy to be an advocate, be a mom, be a pediatrician. That's why I love women. They always seem to be able to pull this out of I don't know where and endless energy to do what needs to be done every day. Thank you. We really appreciate everything you've done, not only for your state, but at the national level.
Thank you.
Pediatric Executive Development System, or PEDS, is a dynamic, transformative program designed to accelerate the growth and development of the leaders in the field of pediatric entrepreneurship. PEDS takes a hands-on approach to problem solving, addressing real-time situations within your organization. More than a theoretical course, it is a practical platform that accelerates learning. Look at our link on the show notes for more information. Thank you for listening. This has been a production of the Pediatric Lounge. On the show notes, you will find links to our co-host and other important notes, as well as a timetable of the topics discussed today. Don't forget to follow us on social media and subscribe to wherever you listen to your podcast. Leave us a great review, as it helps us greatly. In the meantime, we will see you next week. The Pediatric Lounge. The conversations are not intended as medical advice, and the opinions expressed are solely those of the host and the guest.